Hello all, I'm Cole Beeler and we'll be talking about a new procalcitonin algorithm that we will be using to help guide antibiotic decisions for pneumonia. And we see a lot of pneumonia. Community onset disease happens at a rate about 5 to 7 infections per 1,000 patient years, and hospital onset infections happen at about 1% of hospitalized patients. Additionally, we see a lot of stuff that isn't pneumonia but gets treated as such. An abnormal chest x-ray without symptoms, symptoms without imaging findings, a cloudy clinical picture with infiltrate in the setting of maybe a viral infection, congestive heart failure, COPD, interstitial fibrosis, you name it. Pneumonia diagnoses are rarely straightforward, and we're trained to keep multiple etiologies on our differential for newly hypoxic patients. The issue with this is that clinical ambiguity frequently lends itself to prolonged antibiotics, which in turn leads to more costs, selection of resistance, and potentially more complications like C. diff. Now, you might think you're protected against this inertia to give long courses of antibiotics, but at our hospital, the average duration of treatment for a pneumonia is 9 days. I think we are all aware that guidelines recommend a much shorter course. In one meta-analysis, including 2,796 patients, less than 7 days was compared to greater than 7 days of treatment, and there was no difference in success rates for uncomplicated pneumonias. So what accounts for the fact that our clinical practice isn't in line with guidelines or current data? To me, this seems to imply that patient complexity and ambiguity of presentation are dictating antimicrobial prescriptions outside the expected range. And no one would ever suggest that stopping antibiotics prematurely is a good decision when there is potential for multiple variables to contribute to a patient's failure to improve. Wouldn't it be nice if there was a test that could help us delineate when an infection was appropriately treated? Wouldn't it be nice to know that the bacterial infection is done? Now we're only dealing with COPD or the CHF or the influenza. Well, such a test does indeed exist, and it's the procalcitonin. This test is produced by most cells in response to bacterial infection. A meta-analysis in the Cochrane database demonstrated that there was no difference in mortality or treatment failure between groups where antibiotics were guided by procalcitonins versus those that were guided by clinical gestalts in patients from the wards, the emergency department, and the ICU. And when using procalcitonins, mean antibiotic exposure was reduced from 8 days to 4 days, and there were significantly less adverse drug events. This is not the only study. There are large numbers of well-designed, high-quality studies that have addressed procalcitonin guidance and found it to be dominant, really, to the standard of care as it relates to antibiotic exposure. This is not your grandfather's leukocyte counts. This test is a specific physiologic surrogate for bacterial infection in the body. So this is obviously exciting stuff. And there have been a lot of local physician interests in using this test. The problem is that we don't really know what we're doing with it. Physicians are giving 5 days of antibiotics for low procals and even longer courses for high procals. Additionally, low levels prompt escalation, high levels prompt de-escalation, and only single procalcitonins are being used to make the decisions. None of these are really based on the evidence. It's like we've heard of this great new weapon against antibiotic resistance, and we're trying to use it, but we're probably not using it in the safest way. In fact, most studies that have demonstrated success with the use of procalcitonin utilize an algorithmic approach with the support of ID stewardship pharmacists and MDs for accountability. These stewards are already calling your teams and discussing choice and duration of antibiotics. These discussions are based on published data, culture results, and your clinical assessments. And together they came up with a plan moving forward. Since physicians are already using procalcitonins in their pneumonia patients, we've elected to develop an algorithm where the pharmacists can order procalcitonins to help guide their discussions with the teams and add reassurance that antibiotic discontinuation is safe in an evidence-based manner. Our stewardship pharmacists regularly review antibiotics and will be writing orders for procalcitonins on patients with a diagnosis of pneumonia, kind of like they're already doing with like INRs. The algorithm above is our local algorithm adapted from the literature. If an initial procalcitonin is elevated, the test will be trended every 24 to 48 hours until there's a significant drop, upon which time the pharmacist will call the ordering physician and discuss discontinuation. If the initial procalcitonin is low, the same conversation will happen earlier. I would note that nowhere in this algorithm is a hard stop on antibiotics. You can always elect to continue antibiotics since you're the physician primarily caring for the patient. This tool is something the pharmacist can use to discuss discontinuation of antibiotics with you before day 7, which will simplify care for the patient, reduce adverse drug events, and promote cost savings to the hospital. So some take-home points. Procalcitonin algorithms safely reduce antibiotic exposure without increasing treatment failure and mortality, but we are currently using them wrong. So the stewardship pharmacist may be adding procalcitonins on your patients to help guide discussions with you on length of therapy for your patients with pneumonia. Thanks for listening. Email me with questions, subscribe to our videos on YouTube, and follow me on Twitter.